Thank you so much for this kind invitation. It's always a pleasure to join your fabulous society for me. And my topic today will be the diagnosis and classification of perineal abscess and fistula. As you will know, perineal abscesses and fistula are two phases, acute and chronic, of the same perineal suppurative disease. But how do we get to this definition? For sure, we have these two studies. The first one performed on 44 surgical specimens obtained post-mortem or after resection. In this study, the glands of Herman Defoe, first described in 1880, were found in 610 per specimen, and each gland dumped into a crypt. Moreover, in 2 out of 3 specimens, one of more glands entered the internal anal sphincter, and in half of the cases, this gland passed through the internal sphincter and ended up in the interstitial space. The second study was the most important concerning the classification of parts of the fistula, and 400 patients were studied and included, excluding superficial fistula. But let's take a step back, and at 8 weeks of gestation, the anal canal is formed by rupture of the anal component of the cloacal membrane. And everybody knows that this membrane is located to the presence of irregularities, folds of the mucosa, and everybody knows that this is the dentate line. Looking at the anatomy, there's longitudinal folds ranging from 6 to 14 are prominent posteriorly. And between this column, as you can see in the slide, we have the small crypt. This crypt, that are the so-called Morgagni, hide the sinus, which often reach the intramuscular gland. The function remains uncertain, as is a little bit controversial so far. Many are confined to the submucosa, but approximately half of that or more extend transversely into the internal anal sphincter. They produce a mucus discharge that is completely different from the one produced by the rectum, because it's a little bit different in the components. And therefore, the principle, the rationale of the formation of perineal suppurative disease lies in the obstruction of the ducts from trauma or fecal material and formation of perineal abscess. Well, as Sparks has done in his study, Francis Joanne, a very well-known surgeon, studied the anatomy of the fistula through immunohistochemical investigation, and according to Francis Joanne, the median number of anal glands in each anus was 6, and the internal opening were mostly found within the crypt at the dentate line. And also, the authors described the composition, the location of these glands that are mandatory in order to define the fistula tract. And so when we are talking about anal fistula or abscess, we are talking about something that can be tried in the submucosa at the level of the internal anal sphincter, or may involve the intersphincteric space, the elevator ani, or the external anal sphincter. In this slide, you can see the different location of the abscess. we can have an unilateral representation, or we can have also an horseshoe representation of the fistula, like sometimes can happen. So if the abscess is the acute phase, the fistula is for sure the chronic phase. In fact, the one that you can see in the slide is a definition by Parks. According to Parks, in 1961, idiopathic perineal fistula are nothing more than the chronic phase of this infection, this sepsis, that usually starts in the intersphincteric space. Concerning the epidemiology, well, a fistula may be present de novo, but in about 30–50% of patients, it follows a previous anorectal abscess, which can provoke the formation of the primary tract or a secondary tract in about 25% of patients presenting with anal fistula. Mean age of patients with anal fistula is 14, is almost 40, and is more prevalent in men than in women. And of course, the incidence is 2 patients out of 10,000 of patients. Well, during the past, a lot of etiopathogenetic theory have been described, each one with its particular findings. I will try to describe all this theory without going through and lost the importance of this concept. The first one was Milligan with Morgan, that describe considers the high fistula despite the internal orifice at the level of the dentate line. And one of the most important etiopathogenetic theory was by Eisenhammer, that underlined the importance of the intersphincteric space. And afterwards, many other surgeons, considering the different rationale of the fistulas, also in this case, Stelzer about the relationship within the external anal sphincter, and also Golliger. According to Golliger, only 2 out of 3 patients with the perineal abscess may have the communication with the crypt. For this reason, he classified the fistula only superior fistula, complex fistula in ischiorectal, so infraelevator fistula or supraelevator fistula. In this slide, you can see the most important classification, that is the Park classification. That's also now is the most important from the clinic point of view, because we can use the Park classification to classify and for the decision-making process of the surgical treatment. We can classify fistula so in the as intersphincteric, transsphincteric, suprasphincteric, or extrasphincteric, based on the relationship with the internal, the external, and also the other muscle that are involved in the continence and defecation process. In fact, the most common is the intersphincteric one, and this is incredibly related with the rationale that the fistula are coming from the sepsis in the intersphincteric space. Of course, this type of fistula may involve the internal anal sphincter and are simple fistula that may be solved with the fistulotomy and with the simple treatment. The second one are for sure the transsphincteric fistula. We can divide transsphincteric in the high, middle, or low. based on the percentage of external anal sphincter involved in the disease. And in fact, we can define low transsphincteric fistula a patient that in which the external anal sphincter is involved less than the 30%. The suprasphincteric fistula are a little bit different, complex, and are when the fistula tract leaves the intersphincteric space going up above the puborectalis muscles and passes through, at least in part, the levator ani and then reach the skin. The last one is the extrasphincteric fistula, when the fistula tract runs outside the external sphincter and going through upwards the levator ani into the rectum. These fistula are completely different from the others, simply because they can come from diverticulitis, pelvic collection, or other disease such as Crohn's disease or ulcerative colitis. In terms of surgical treatment, it's really important to classify fistula using this classification, that is the classification made by the AGA, so the Gastroenterologic Association. Simple fistula are intersphincteric fistula or transsphincteric fistula in which the external sphincter is involved less than the 30%, or submucosal, so superficial fistula. Conversely, the complex fistula are the ones that require a really challenging treatment, not a fistulotomy, but probably a two-step treatment at least, even if normally we must perform at least 3 treatments for patients in this case. And so complex fistula are fistula in patients with IBD, for definition. Women with fistula are, especially with an anterior fistula tract, have a complex fistula, or patient with malignancy, patient with incontinence or previous treatment in which the continents are a little bit damaged from previous treatment. And the complex fistula are also high transsphincteric, suprasphincteric, or extrasphincteric fistula. Also, patients may be elderly with chronic diarrhea, can be considered patient with a complex fistula. Apart from the classification described by Parks, in the last few years, a lot of authors described the other type of classification in order to improve the outcomes, to standardize the outcome. In surgery, we had some problem with classification because as surgeons, we are really simple, sometimes romantic people. So we love simple classification without the complex one. And these colleagues proposed a modification of the Parks classification, starting from the analysis of the predictive factors of failure that are the secondary tract, fistula tract, or show fistula, recurrent fistula, or anterior fistula in women. They divided transsphincteric fistula in 2 groups, high or low, and they grouped it over and the extrasphincteric. The first 3 stages were subdivided according to the absence or presence, as you can see in the table, of predictors of failures. Conversely, the stage 4 are suprasphincteric and extrasphincteric fistula. And so the area under the curve was indicating the strong discriminative ability of the final multivariable predictive model that this author described. Of course, the increase in failure and incontinence rates across the fistula was significant. Going through the classification and the diagnosis afterwards of the fistula, we can say that the diagnosis depends on the clinic. In fact, patient history, rectal examination are mandatory in patients with fistula. And there are also other important things, such as the Goodsell's rule. The Goodsell rule states that the fistula with external opening anterior to this imaginary transverse line across the anus as its internal opening at the same radial position. And for external opening posterior to this line, the internal opening is in the midline posteriorly with the horseshoe tract. So completely different. Usually the internal opening of posterior fistula is at 6 o'clock with the patient in the lithotomy position, whereas if you have an anterior fistula, usually there is a direct tract and the internal opening is at the same hour, at same position of the external opening. A really important consideration concerns the evaluation under anesthesia, because sometimes the diagnosis of the fistula and the proper definition of the different tract is really demanding and challenging. And for this reason, a lot of European Society, the European Chronic Colitis, and also the Italian Society of the Gastroenterologists gave a really important role to the evaluation under anesthesia in order to better classify the complexity of each fistula. Moreover, especially in Italy, not a lot in the UK, the endoanal ultrasound is one of the most important instrumental things and stuff that we can use to define and to decide the surgical treatment. So, as I already told you, the diagnosis of perianal fistula it's really difficult without the digital rectal examination. That is the most important things. There is a study published by the San Mark Group many years ago. According to this study, the rectal digital examination is important like the endoanal ultrasound, especially if performed by an experienced own surgeon. And concerning symptom and sign of the fistula, for sure we have the mucus discharge, discomfort, pain, and moreover, the other symptoms really depends on the disease that can be at the base of the disease. For example, if we have a fistula in a patient with Crohn's disease, we will have bleeding and also diarrhea and so on. For this reason, the symptoms are based on the other disease that can be associated to the fistula. Of course, sometimes there is a possibility of neoplastic transformation of the fistula, such as in this case. In my experience, I had 3 or 4 patients with this transformation, but in the literature there are many described, such as in this case, less than 1% in the literature. These are the case of a 40-year-old man that was transferred from a rural district for this management of a chronic buttock abscess. He has had 3-4 episodes of abscess over the last 20 years without any diagnosis of a Crohn's disease. but afterwards, after repeating the MRI and also colonoscopy, he had the diagnosis of Crohn's disease, and biopsy were taken from the ulcerating lesion that you can see in the slide, which demonstrated moderate differentiated squamous cell carcinoma. And also in the colonoscopy, there were multiple enterocolic fistula. For the reason, after evaluation under anesthesia and sepsis control, the patients underwent diverting loop sigmoid colostomy and afterwards chemoradiotherapy. For this reason, depending on the location of the malignancy, on the presence of the distant disease and the histology of the biopsy, the treatment may include sometimes a combination of mild procedure and also neo or adjuvant chemotherapy. Of course, it is well known that the presence of the lymph node metastasis can modify and alter the prognosis. Just to go into the conclusion of my presentation, this is one of the last publications concerning the cryptoglandular theory. I invite you to read this article because it's really interesting and went through all the difficult points that that may be discussed according to the controversial point included in the Parks classification. And in fact, there are a lot of articles published and discussed in this editorial, but most of all, there are 4 or 5 points that are really important. The first one is the abscess fistula sequence, because not all fistula came from an abscess, because one of the most debated points is the higher incidence of the internal opening at the posterior quadrant, because this greater incidence is difficult to explain if the anal glands are equally distributed circumferentially in the at level of the anal canal and the rectum. The third point is a male-female ratio, because from an epidemiological point of view, the cryptoglandular theory is not sufficient to explain the difference between male and female. And finally, the epithelialization, because we generally accepted that epithelialization of the anal tract causes the persistence of anal fistula. But recent studies show a lack of epithelialization and the presence of granulation tissue in most fistula tract. Thanks for the attention, for the invitation of to show this topic that for me is really important, and I really apologize for the delay.
Thank you very much, Professor Gallo, for this presentation. We are so grateful for you honoring our invitation. And I've followed Professor Gallo closely based on his scientific and research output over the years. And he has a very exciting social media profile. It's a pity that we didn't see his video of himself in the presentation. But thank you so much, sir, for this. And can I hand over to Mr. Aguirre to coordinate the Q&A session, so if you don't mind, sir.
Okay. Thank you very much, Professor Gallo, for this very informative presentation. I was just wondering, is it possible to go back to the gallery so that we can all see ourselves? And
Can you do that?
okay. Can you hear me? Yes. Yes. Thank you very much, Professor Gallo, for that very interesting and educative
Thank you so much.
Yeah, presentation on anal fistula. And it's quite interesting to know that such a little thing in that area where the sun doesn't shine can cause so much trouble. Yeah. I just have a few questions for you. One of the complexities is trying to differentiate between infrasphincteric, transsphincteric, intersphincteric, and supralevator. I know you mentioned the ultrasound. What do you think about pelvic floor MRI now? Are they as good as 3D ultrasounds, or should we all still go with the ultrasound? Because I know the ultrasound is really user dependent. You have to be good at doing it to be able to get very good images. So what is your view about MRI investigating these patients?
Well, I agree with you, first of all, because the ultrasound is a powerful instrument that we can use in the diagnosis of anal fistula, and it's really helpful to decide the correct treatment. But it's important to say that the experience of the men who perform the ultrasound is really one of the most important things, because without experience, endoanal ultrasound is not so useful. And the crucial things is that usually surgeons perform the ultrasound, and so based on the ultrasound, we can also decide the treatment that we're gonna perform. So this is completely different because the clinics is in our end. Of course, the MRI in patient with complex fistula, I think is mandatory. It's mandatory for many reasons. First of all, because even if we use the 3D ultrasound, we cannot establish the whole fistula tract, because maybe we not have the correct view, especially in patients with diverticulitis, Crohn's disease, and so on. And so maybe in patient with Crohn's disease, the MRI is mandatory. It's mandatory. And the second reason is not only for the surgical decision-making process, but from a legal point of view. In Italy, we have a lot of problem. Augustine can confirm this. And so the MRI can help also the surgeon to underline his decision, make his decision, her decision strong, and so on. So simple fistula, if we have the endoanal ultrasound in our outpatient clinic, we must perform it. Afterwards, if it's not completely satisfactory, we can ask the patients to go to perform the MRI.
Great. Thank you so much. Thank you so much. I think I'm very happy with the response there. I'll just ask one more question before I throw it out to the audience. There's this rule of Gussos that is still continuing to cause a lot of controversy. I know with the new definition that any fistula that is more than 3 centimeters from the anal vag does not necessarily obey the Gussos rule. So I want your view there. Do you still stick by Gussos rule that if it's anterior to the transverse line, it has to open radially and posteriorly, or do you believe, like the complex fistulas, that could be more than 3 centimeters from the anal vag? And then the other question I want to ask is, what's your view about using sit-on drains rather than surgical interventions at the onset for treating these patients?
Okay, yes, thanks for this question, because they're very interesting. We can also discuss about anal fistula for hour and hour, I thought. And the first question concerning the Gussos rule, according to the literature, the power of the Gussos rule concerns the posterior fistula. So the fistula that are located from T to 9 o'clock in the lithotomy position, 80% in the literature. For anterior fistula, we have a lot of problem. because using the good cell rule, you can do a lot of problem, especially in female patients, because you can do false tract and so on. So I think that the good cell rule can be useful in our mind to plan the procedure, but afterwards, once we have taken the patients in the OR, we must be very, very careful in the location and identification of the internal opening. Even if, of course, we will use the endoanal ultrasound, MRI. So the good cell rule was very important in the past, but so far it's just an empiric role that can just help us in the moment that we see for the first time the patients. The second question is concerning the ceton. Well, there are some studies, especially in patients with Crohn's disease, that use the ceton for the symptom control. And the ceton is for sure useful. We have not a lot of level of evidence concerning the power of the ceton in terms of success rate, but the ceton maintains its role in the control of the disease in the acute phase. In Crohn's disease, I have a lot of colleagues that remove the ceton and has a success. But so far, we cannot base our clinical practice on that. And so the conclusion is that the ceton is a key process in the treatment of anal fistula, but 2-3 months after, we must decide the proper treatment. Maybe ceton can help us also to think about the correct treatment to use in patients with anal fistula, and to take our time to decide the treatment.
Yeah. Thank you very much, Professor Gallo. There is a question here. Somebody, Dr. Ladios, asking a question. What are the treatment options for the treatment of complex fistula with incontinence?
Well, we in case of complex fistula in patients with incontinence, so also an intersynthetic fistula in an incontinence patient is complex, of course. And we have a lot of options. First of all, the sphincter saving procedures. So maybe stem cell, glue, as first treatment, and afterwards we can think about the mucosal flap or lift or direct closure with the stitch of the internal opening. But also this treatment can change just a little bit the continence of the patients, the resting pressure, especially 8-10% of incontinence concerning the resting anal pressure. And for this reason, the first choice can be the permacol, for example, or the stem cell.
Thank you very much. I think I'll have a question there later on, but Dr. C.J. Okeke has a question. Dr. Okeke, can you hear us? You are muted. Dr. Okeke, can you hear us?
I can hear you.
Okay, great. Yeah, you have a question for Professor Gallo?
Yes, thank you, Prof, for the beautiful presentation. Please, my question is concerning secondary tracts. How can we differentiate between secondary tracts from the primary tracts of the disease? And because I'm talking about, because in treatment, sometimes you see you can tackle the primary tracts as in fistulectomy, and you identify the secondary tract still going proximally as in superiorly. And there's always this fear that one can cause incontinence. And again, do we have to excise or tackle secondary tracts all the time? Or is it just enough to take care of the primary tracts? So in summary, how do I differentiate between the two? And is it always that we must have to, remove or excise all the secondary tracts in treatment? Thank you.
Really interesting
Gaetano, posso
question.
parlare?
Sì.
Okay, I think that would have been very
Augustine.
interesting. My presentation would have tackled that issue.
Okay.
Gaetano, posso parlare, vero?
Of course.
Okay, so let me respond to him. My presentation would have tackled that issue. The secondary tract, yes, exists, but then it comes from the primary. So if you can drain the secondary tract and try to close the primary, you can have a good result. But you need to make a diagnosis. You need that ultrasound or with your MRI, as Dr. Iguari has said. MRI will help a lot to make that differentiation. But what matters most, the primary tract, you call it primary. That's the most, the beginning of it all. Beginning of it all, if you can identify it and put a seat on it, then that's what we do. If you can put a seat on that first one, then the secondary tracts can be taken care of, because they are only deposits of the derangement due to breakages in the primary tract, or due to, I think sometimes it is iatrogenic too. So I think the best way to identify it would that be with the MRI. Once you do the MRI, identify the primary tract, get hold of that primary tract. The secondary tract will succumb if you just put a sit on it.
Thank you very much. Yes.
Yeah, the problem is that sometimes we do not perform the procedure on the picture, and the diagnosis of the MRI is sometimes different from what we find in the OR. So I completely agree with you, Augustine. But in anal fistula treatment, less is more. So if we have some problem, yes, less is more always.
Yes.
It's a step up. Right. It's a step up approach. So if we are not sure that we have found all the secondary tract, we can always put the seat on and come back after 2 months, because this is not a failure. This is more, as I told you, less is really better in the surgical treatment of anal fistula. Of course, the fistula tract are always connected. So doing the fistulectomy very careful and putting a seat on, we can find all the tract, I think.
Yeah. Thank you very much. I think I agree with you, and I think I agree with that principle of less is more, because I've recently really gone away from excisional surgery for fistulas to just draining these patients to control the sepsis and define the anatomy. And what I use for treating many of them now is radiofrequency ablation. Just introducing the catheter into the ROFA catheter into the tract, and it will go as far until you're able to track it into the internal opening. And as you're withdrawing it, you're sealing the tract with radiofrequency ablation. That seems to have been working for me, and that means you don't have to destroy or damage the sphincter component, the sphincter complex at all.
Yeah, that's correct, Dr. Guare. But that raises also an issue of ethics. Now, he has correctly mentioned that sometimes you have cancers in the fistula tract, So what we're really debating yesterday when I was with works, now we were talking about is this VAFT, lift, FILAC, advancement flap that leave the tissue there. Are we really say it is true the percentage of cancer occurring in fistulas is low, but who knows which? Who knows which? So that's it becomes a question of I think a question of ethics. Are we really doing the good job? If Professor Gallo did not remove those fistulas, wouldn't have known there were cancers there. So that's it's true. FILAC, as you say, we'll take care of that. We'll close it, but then later on it will be open again. Yeah. But the question is if we have left something good or something bad, the ethical part of it.
Yeah, again, I guess that will be balanced with, like you said, less is more. And we know that majority of fistulas will be benign. And so if we approach them with conservative approach to treat them initially, I mean, if you have persistence of fistulas, that's one of the reasons that will make you even begin to investigate further. Is this inflammatory bowel disease? Or is there underlying malignancy or chronic granulomatous disease that will account for that? So I think I agree with you, but to go straight to very aggressive surgery in the first place, particularly where you have cryptoglandular abscesses, it might, so if you treat a fistula and then they reoccur, that might increase your suspicion.
Okay.
And there's an underlying pathology. Dr. Adeye, you have a question for us?
Yes, sir. Thank you, sir, for the opportunity to speak. I actually have a group of questions. I'll categorize them into three parts. The first part is as per evaluation. We live in a resource constrained environment where we don't have really access to pelvic MRIs. And endoanal ultrasound scans are either not available or don't have the expertise to conduct that. So I know many of the people on this call have used fistulograms, that is contrast radiology, to outline the tract in the past. So I'd like to know what the opinion is of our experts in the room as per the role of fistulograms. The second question on evaluation is what the role of microscopy culture sensitivity of the perineal discharge will in terms of treatment and outcomes. I know in the UK, some of our colleagues actually insist on doing a microscopic culture sensitivity to see if we're dealing with gut flora or Staph aureus as organisms predominantly within the fistular tract. I wanted to know our opinion. So that's as per evaluation. As the second question is as per intraoperative localization of the tract. I know we didn't have opportunity to talk about treatment, but I'd like to find out what is the recommendation, what as per experience and guidelines on how to localize intraoperatively the tracts, internal opening of the tract. And then the final group of questions was actually about options of treatment. I know we didn't have opportunity to talk about this in detail in a didactic manner, but I know a lot of people want to find out the role of fistulotomy versus fistulectomy. In terms of seton, what kind of material do you use for seton, and when do you use draining or cutting setons? And then those aggressive procedures we've mentioned, the lifts, the RFAs, sometimes even plugging with fibrin glue. And then at what stage we consider doing a diverting stoma for our patients? And those are my questions. Thank you.
Great. Thank you so much. We'll let Professor Gallo have a go at some of those questions. I know I talked about intraoperative localization of the internal opening, fistulotomy versus fistulectomy, the role of diversion, colostomy, or when do we consider that, and then the use of microscopic culture and sensitivity for directing your treatment.
Okay, so I don't know if I can be able to answer all the questions in order. So concerning the fistulogram, it was used many years ago. And in Italy, I know that there are a few centers that used it. It's not a bad solution, but I think it can use. However, the level of evidence for this type of instrumental test is really low so far. Concerning the culture, it's important. The culture we do not do it in the OR, but there are a lot of studies, as you mentioned, that consider it, especially because the type of bacteria involved in the different disease are distributed properly. I mean that in Crohn's disease, there are different bacteria with respect with the cryptoglandular fistula. So it's really proper question. And maybe, I don't know if in the future we will have an evolution of this, but I showed you the study published by the San Mark group in the last study, and the idea is correct. They're all the function colostomy. The colostomy or loop ileostomy or the functional ostomy is crucial in anal fistula. And just think that the 20-30% of patients with Crohn's disease, with perianal fistulitis in Crohn's disease, have the function colostomy or ileostomy. So 1 out of 3. And this is important because based on this percentage, we can understand the complexity of the perianal fistula in patients with Crohn's disease. Concerning fistulectomy and fistulotomy and the way to localize properly the perianal fistula in the OR, I think that the surgeon experience is the most important way to do this without any damage or false tract to be formed, especially so to use a fistula probe really without carefully, I mean really carefully. And of course, based on the report of the endoanal ultrasound report, as well as the MRI.
Great.
And also there is the video anal assisted, the VAFT, the VAAFT, that is a really good solution from the diagnostic point of view, because the solution is not with the VAFT, but is with the closure of the internal opening. But if we have this instrument, we can use it.
Thank you very much. I mean,
and sometimes let me add something to that.
Yeah.
To the to locating the internal opening, Dr. Deyeye. Something, if you are sure you have the external opening, and if you inject hydrogen peroxide and put your deferricator in the anus, you can follow it up and see where it bursts. So that's very helpful. But as Professor Gallo has said, it's very, very important not to insist. If you don't see it, don't insist, because you may be creating false tracks.
Yeah.
Okay.
Thank you so much. I think that was exactly what I wanted to say, that in resource-constrained environment, just using hydrogen peroxide instillation, using an IC-hammer endoscope will help you. If you see hydrogen peroxide in the rectum, then it means there's an internal opening. But if you don't see it, then trying to pursue it will just end up in creating a false tract. Dr. Callistus.
Good evening, Professor Gallo and members of the team. Thank you very much for the presentation. I just want to find out what is his experience with recurrent fistulas. Thank you very much.
Sorry, say it again.
Yeah,
Sorry.
What is your experience with recurrent fistulas?
Yes, recurrent fistulas are complex fistula. So, I mean, there are a lot of solutions that are exactly like the ones that we considered for the complex fistula. A good point of view is the discussion can be made from the discussion with the patient. It's a really challenging problem. I mean that sometimes patients, men with complex fistula, may accept a little bit of incontinence after many treatments, after many failure. That sometimes I remember what Robin used to say that it's not important how many sphincter do you have, but how much sphincter we leave after the procedure. And so sometimes the levator can help the sphincter complex function also after a fistulotomy in medium high transsphincteric fistula or recurrent fistula in which the patient would like to solve the problem at all.
Thank you very much. And Professor Gallo, I have 3 questions here for you, but before I do that, I just answer the last question there. How about injecting methylene blue? I think with the advantage of hydrogen peroxide over methylene blue is once you inject methylene blue and it stains the tissue, it's difficult for you to repeat the procedure. So you're not able to tell the tract from no tract because the blue just messes up everything. But hydrogen peroxide is very neat. If you inject it and you can't find something, you can inject it again and you can always repeat it. But methylene blue will stain or contaminate the tissue. But Professor Gallo, we have 3 questions here. I'll just read them out for you and then you can answer them in order. The first one says, is there a place for defunctioning colostomy in the management of supraelevator fistula? I think you've kind of had answered that before, but I'll appreciate if you approach it again. And then the next question, treatment option for a fistula complicated with Fournier's gangrene. Okay, I'll leave we'll address it. And then the third question is, how do you confidently identify the primary tract from the secondary tract? What does one do for a patient with persistent recurrent fistula?
Okay, concerning the last question, the latter one, I think that Augustine answered very well concerning the MRI and so on. So we have already answered this question. Concerning the first one, the function in colostomy, there is a clear role, especially in patients with complex fistula or with recurrent fistula, or in patients with Crohn's disease, in which can be really helpful. Concerning the second question, so Fournier gangrene, it's a completely different treatment. I mean that sometimes the Fournier is a complication of a surgical treatment. So you can have a patient with Fournier gangrene after hemorrhoids treatment or perineal and so on. And there is a place in the Fournier gangrene for the colostomy, because it's important to the sepsis control in this case. Apart from the colostomy, I think that the debridement is the first option in patients with the gangrene. I mean that the tissue is a completely different disease. It's not like the a perineal fistula. So colostomy for sure, and afterward debridement, if maybe a flap, or you can ask help to your plastic surgeon.
Thank you very much, Professor Gallo. I know we are running short of time now. In fact, we've overshot our time, but I appreciate the detailed answers and comprehensive answers you've given to all our questions. And I think, just to be fair, there's somebody that asked a question here. I think that would be the final question we'll entertain tonight before I hand over back to to Mr. President. And somebody said, I'm not clear on the role of the MCS. I know, and Dr. Adeye mentioned it, that this has been done in the UK, where people do cultures. And I think Professor Gallo also said it and mentioned it, that the evidence is quite low for this, because if there's a fistula, an anorectal fistula, you're going to get enteric organisms anyway. So apart from telling you what sensitivity they are, it doesn't really direct how you treat the fistula, particularly depending on the anatomy of the fistula. That would be my position. I don't know if Dr. Gallo or Dr. Ratulam have any view on that.
Yeah, but just completely agree. Just remember in our mind that we have different bacteria. So, for example, the Escherichia coli can be not represented if we have a verneuil disease, and so maybe in the future we will have a place also for this exam. Maybe in the future, but not now. It's just a secondary exam.
Thank you very much. And I want to thank Professor Gallo again for this very enlightening conversation we've had this evening on the anal fistula. But please, if you still have other questions and comments, please leave them on the platform so that we can all learn from it. And if there are questions that have not been fully answered, please post them on the WhatsApp platform, whereby we can all have a conversation. In the absence of any other comment, I'll hand back to Mr. President. Dr. Dijumo, are you there?
Yes, I'm here, sir.
Okay, over to you.
Thank you very much, sir, for that. We want to appreciate Professor Gallo once again. And at the same time, we want to apologize that we could not take Dr. Rotuland's presentation because of technical issues. I think even if it was ready, there will be some time constraints regarding the two presentations today. So we apologize for that. And I think we are going to take Dr. Rotuland's presentation during our next meeting, because I'm sure that it's going to take some time and there'll be a lot of issues that will come out of it so that people can learn as much as possible. Be that as it may, today's meeting will be posted on our YouTube channel. So if you want to have a look again or listen to the presentation again, I think Dr. Gallo will oblige us the slides so that we can post it on our YouTube channel for our members to see. I thank everybody for attending this meeting. And I don't know whether Dr. Adeyeye has any information for us before we shut down for today.
Thank you, sir. Initially, we were supposed to announce the itinerary for next month's meeting. But now that we have to take first Dr. Rotuland's pending presentation, we would have to discuss and see how we work things out. But I know that we have the OGM, mid-year OGM that we plan to do. We'll have to discuss about that, sir. But at least tentatively, we take Dr. Rotuland's presentation and probably the OGM.
Okay. I think we will sort that out at the ESCO level and get back to the general house within the next couple of days. Yeah. I also want to appreciate our trainers who deemed it fit to be in this meeting. We appreciate Professor Ismaila from Jos. Let me say that I did my senior residency training in Colorado under Professor Ismaila, and I really appreciate his mentorship during that period. Also, we have Professor Ugu, who is always present with us, Professor Bakari, all the way from Maiduguri. Professor Guntola, I think I spotted him some times ago. Dr. Buola from Belarus. We really appreciate everybody for their contribution towards our meetings. And with your permission, we have already spent about 12 minutes past the scheduled hour. but I think it's a time that is well spent anyway. With your permission, I think we can declare today's meeting closed. Like what Dr. Igwari said, if you have any pending questions or queries, you can always put on our WhatsApp group for discussion. You can always post it on our WhatsApp group for discussion, and we are going to upload today's meeting on our YouTube channel. Once again, I thank you for coming, and I wish you a pleasant week ahead.
Thank you.
Good night, everybody.
Bye-bye.
Good night.
Bye-bye.